I'd say the big take home message is that diversity and access are not the same as equity. That is what the insurance industry has been trying to tell legislators and the public about why Medicare Advantage is a good program.
911, what's your emergency?
America's healthcare system is broken and people are dying.
Welcome to Code WACK, where we shine a light on America's callous healthcare system, how it hurts us, and what we can do about it. I'm your host, Brenda Gazar. This time on Code WACK, how does Medicare Advantage, also known as privatized Medicare, fail seniors, and especially seniors of color? And how can these plans deepen racial and income disparities when it comes to access to care? To find out, we spoke with Dr. Belinda McIntosh, an Atlanta-based psychiatrist with more than 20 years' experience, a board member of Physicians for a National Health Program, and co-author of a new PNHP report titled No Real Choices: How Medicare Advantage Fails Seniors of Color. This is the first episode in a two-part series. Welcome to Code WACK, Dr. McIntosh.
Thank you so much, Brenda. It's so nice to be here.
So nice to have you. So before we dive into the new report you co-authored about seniors of color and Medicare Advantage, we would love to get to know you. Who are you? And how did your journey as a physician lead you to health policy and advocacy with Physicians for a National Health Program?
So I'm a psychiatrist. I trained at Emory, and I've lived in Atlanta since I came to do my medical training here. And I work at a very large urban hospital right in the center of the city. You know, my day-to-day work, I'm confronting the issues around health equity every single day. But how I really became interested and got involved with PNHP was through a mentor of mine, physician teacher that I had. But it wasn't until I was finished with residency, went into practice, and I was actually working at a university mental health center at the time. And I was working with people who have depression and anxiety. They're young adults trying to adjust to a different kind of life. Some of them are in graduate school, lots of pressures. And occasionally I'd have someone who developed a very severe mental health problem. And, between the ages of 18 and 25 are sort of the highest risk times for people who are going to develop a serious and chronic mental health problem. That's when it tends to occur. And so often if I had a student who got really sick with, let's say they had symptoms of schizophrenia or severe bipolar disorder, and they had to withdraw from school for the semester, potentially longer sometimes, I realized that the students that were covered under this wonderful comprehensive student health plan that our university offered suddenly were going to lose access to their health care at exactly the moment that they needed it the most. And I would say that that's when I really became deeply concerned about our healthcare system. And it was interesting because it was right around the time that the ACA, the Affordable Care Act, was being passed. And so there was this period of this is exciting. I have students who are now 22, 23, 24 who can continue on their parents' health care plans if they have a parent who can provide that for them, up until the age of 26 who would not have had access to health care before then. And then I have these other students who are covered under this wonderful health plan, very similar to what I had as a faculty physician, and they were going to lose coverage. And so I wrote an article in a Journal of American College Health entitled Students Left Behind: How University-Based Insurance Fails Students with Mental Illness. And what I realized is this is the story of our health system. Most of our health insurance is tied to employment, and just when people get really sick and can no longer work, they lose access to their benefits. So that's a part of how I became really energized about this. And then I joined PNHP and I've been active in that organization. It's been great.
Wow, what a powerful story, and how true that is, that our healthcare system fails people when they need it the most, which is tragic. The PNHP report is called No Real Choices: How Medicare Advantage Fails Seniors of Color. If someone only remembers one thing from this research, what should it be about Medicare Advantage and seniors of color?
I'd say the big take-home message is that diversity and access are not the same as equity. That is what the insurance industry has been trying to tell legislators and the public about why Medicare Advantage is a good program. Our organization and other folks have blown the whistle on Medicare Advantage programs. There are massive amounts of overpayments, and there are all sorts of fraud and waste going on in Medicare Advantage. And how they've been countering that in recent years is saying, but hey, hey, our plans enroll so many seniors of color, we are actually advancing health equity. And it's simply not true. And this report pushes back on that very sharply by saying just because you have more people from minority groups signing up for Medicare Advantage now, which is true, Black seniors and other folks of color are signing up for Medicare Advantage over traditional Medicare at a much faster rate than white American seniors are. But the trouble is that they're mostly ending up with lower quality plans. And so just because you have more Black people in the plan doesn't mean that the plan is more equitable if the plans are not equal. And we see this play out in various ways in terms of access to care, cost-related barriers to care, and health outcomes.
Right. You introduced this powerful idea called the gap trap. Can you walk us through what that means in real life and why it leaves so many Black and brown seniors feeling like they don't actually have a choice at all?
Yes, so I would say this is probably the second most important point from this report that we just released. And it's that this concept of the gap trap is basically related to how traditional Medicare works. So when seniors turn 65 and they get to sign up for Medicare, now they have the option of signing up for Medicare and they have the option of signing up for a Medicare Advantage plan. The problem with traditional Medicare is that people who have lower income might be able to sign up very easily for traditional Medicare, but traditional Medicare doesn't have a cap on out-of-pocket expenses and it doesn't cover supplemental benefits. And so seniors who sign up for traditional Medicare are often also signing up for Medigap, which is another plan, a separate plan called Medicare Part G, which covers a lot of the things that traditional Medicare doesn't and allows people to have a cap on their out-of-pocket expenses. Now, if you have very low income and you can't afford the premiums of the Medigap plan, you don't really have a choice to sign up for traditional Medicare. And here come the Medicare Advantage plans advertising their lower premiums and their out-of-pocket maximum to constrain your healthcare costs and their supplemental benefits like dental and vision and hearing. And when you're a fairly healthy 65-year-old and you're being wooed by a plan that has supplemental benefits and even a gym membership, a lot of people will sign up for these plans. So we call it the gap trap because it's a false choice. People who have lower income aren't choosing Medicare Advantage over traditional Medicare. They simply can't afford the premiums of the Medigap plan, so they can't afford to just sign up for traditional Medicare. Otherwise, their financial exposure is out of control. If they get sick, they could just have healthcare costs and no coverage. So they're not choosing, they're relegated to these Medicare Advantage plans. And what we find is that seniors of color are often being shuttled into finding themselves in catchment areas where the lower quality plans are actually what's offered in their area.
Wow. So Medicare Advantage is constantly marketed as offering more choice and more benefits. At what point does that promise break down for people who actually need care?
So what we find in Medicare Advantage is that there's a real push to sign people up when they're young and they're healthier. And a lot of people who sign up for these plans, they have lower premiums, they have dental benefits, vision, etc. However, when they become sick, that's when they realize that these promises of coverage start to fall apart. They're immediately going to be hit with prior authorizations in the Medicare Advantage plans. Prior authorizations are extremely rare in traditional Medicare, whereas anyone who has a Medicare Advantage plan, they're dealing with prior authorizations 90+% of the time. So prior authorization basically is the insurance company saying, yeah, your doctor may think you need that medicine, but we don't approve it yet. You guys have to prove to us that you need this, or you have to try this alternative that is on our list of approved medicines first, and then. And so when people actually become ill, they find out a couple of things. One, their medication is harder to get because they have prior authorizations they have to go through. Number two, the physician networks are narrow. So they advertise these big networks, and they're actually called ghost networks. And the reason we call them ghost networks is because the plan has a database that looks like it has lots of providers. But when you start to call providers to find out if you can go to see them, you will hear messages that say, I'm not a network for that plan. I'm not in that plan. And so the networks are actually much narrower than people think. So sometimes people will sign up for the Medicare Advantage plan. This happened to a patient of mine, signed up for a Medicare Advantage plan when she was originally on traditional Medicare because she needed some dental work done, signed up for the Medicare Advantage plan and found out that the clinic she'd been going to for decades that was keeping her well when she was being treated for a severe chronic illness no longer was in her network. And she was faced with huge hospital bills as a result of that.
That's so unfortunate. Do you know what ultimately happened? Did she have to declare bankruptcy, or how did she cope with all that?
She is actually still coping with it. She's still coping with it. She's gone to the hospital, financial services. She's talked with me about it. Ultimately, when she got the most important dental work done, we did lots of discussion about it. And she chose to go back to traditional Medicare. And she's still got unpaid hospital bills that are stressing her out that she literally cannot pay. And there's really nothing she can do about it. Now she's carrying medical debt, which is becoming more and more common in our country for people to just have medical debt they simply cannot pay.
Wow. And I know many people aren't able to switch back once they have Medicare Advantage.
This is an important point you're raising, and it's another version of the Medicare gap trap, right? So there's the initial trap, which is you can't sign up for traditional Medicare unless you can afford Medigap, right? The other part of the trap is that if you choose the Medicare Advantage plan, let's say you're young and healthy, 65, 66-year-old, and then you get sick and you're 70 or 75, and you realize they're pushing you out of the hospital before you're ready, or you can't get your rehab approved, through your insurance company, and you realize your plan's failing you try to go back to traditional Medicare, you can always sign back up for traditional Medicare. We all over 65 are eligible for traditional Medicare. However, the Medigap plans are insurance plans, and they can say, oh, you've got pre-existing conditions. They can have higher premiums for you. And so you end up trapped in the Medicare Advantage plan because you can't afford to go back to traditional Medicare because you can't afford the Medigap plan, which you would have been able to afford it when you were 65 and healthy. But now when you're really sick, you can't go back.
Right. That seems like a flaw in the Medigap system. The Affordable Care Act outlawed most pre-existing conditions, but it sounds like in this one area, it did not outlaw pre-existing conditions.
Yes. Yeah, Medigap plans are able to treat people differently based on pre-existing conditions. They might no longer qualify for the same plan.
So one of the most striking findings in the report is that Medicare Advantage plans are effectively sorting people by race. How does that happen? And why should that alarm all of us?
So CMS, the Center for Medicaid Services, that's who's over Medicare and Medicaid, actually incentivizes Medicare Advantage plans for signing people up. And they will give bonuses to insurance plans based on how many people they're able to get on the plan. They will assign bonuses if there is lower than average traditional Medicare spending in that area. And lower than average traditional Medicare spending really just means lower healthcare spending in that community, right? So healthier communities get certain bonuses and then are able to pass those on to people in their plans in the form of supplemental benefits or lower premiums. But what we did notice when we looked at some of this Medicare Advantage plan data is that 25% of Medicare Advantage plans are enrolling people of color at a higher level than would be predicted by the demographics of that geographic area. And we think that this is primarily driven by income because these plans attract seniors who are looking for lower premiums. And so that's actually driving a lot of the enrollment into Medicare Advantage among people of color and people with lower income.
And so what is the effect of that if more people of color are signing up for Medicare Advantage plans? What do you think the impact on their health is?
So when we compare people who are in Medicare Advantage plans to people who are in traditional Medicare plans, Black people and other people of color fare worse. And one of the outcomes we looked at was rehospitalization after surgery. You had a surgery, you were recovering in the hospital, you were well enough to go home. You go home, you have a complication. If it's severe enough that you have to be readmitted to the hospital, that's considered a pretty negative outcome in healthcare. And when we looked at rates of rehospitalization after surgery, between traditional Medicare and Medicare Advantage, the numbers were worse for the Medicare Advantage plans. But when you looked within the Medicare Advantage plans at how Black enrollees do versus white enrollees, the rates of rehospitalization after surgery for Black enrollees in Medicare Advantage was way worse.
Wow. So why do you think that is?
It's unclear, but I will give you my best understanding of that. This might be fairly clear if we look at it from the standpoint of structural racism throughout our healthcare system. When you look at rates of rehospitalization after surgery between Black and white individuals, even in traditional Medicare, Black patients fare worse after surgery. And that's simply because we live in America and structural racism is a part of our healthcare system. And so Black people tend to have worse outcomes. However, the difference in outcomes between Black and white enrollees in traditional Medicare is not as great as the difference between outcomes in Black and white enrollees in Medicare Advantage. So it actually amplifies the inequity when you look at that particular measure of health outcomes. One of the reasons we think this happens is because let's take the white enrollees in traditional Medicare versus the white enrollees in Medicare Advantage. Maybe you've heard about upcoding in Medicare Advantage plans. That's when the plans make a patient look sicker so that they can generate more healthcare billing dollars and more reimbursement from CMS. So we think that what's happening with the white patients is they were probably healthier to begin with, were upcoded, and had a net positive outcome. And we're not seeing the same with our Black enrollees in Medicare Advantage. And part of that also is that the structural issues of race and economic circumstances are different in our system, and people from lower income communities and people full of color have worse health outcomes because of the barriers that exist throughout our system. Medicare Advantage just amplifies that. So some of the other pieces that go into that are cost-related barriers to accessing care. So we think about things like when you're having to choose whether you can go to the doctor or not, whether you can fill your prescription or not, and people in Medicare Advantage plans, despite all of the promise of lower costs, lower premiums, and people sign up, when they actually begin to use their health insurance because they need health care, their out-of-pocket expenses end up being greater. And so they face more cost-related barriers to care than people in traditional Medicare. What happens? People get less health care.
Thank you, Dr. Belinda McIntosh, from Physicians for a National Health Program. Stay tuned for next time when we continue our discussion with Dr. McIntosh about how Medicare Advantage plans hoodwink and harm seniors of color. Do you love Code WACK? Keep us on the air with a tax-deductible donation at heal-ca.org/donate. Do you have a personal story you'd like to share about our WACK healthcare system? Contact us through our website at heal-ca.org. And don't forget to subscribe to Code WACK wherever you find your podcasts. Code WACK's powered by Heal California, uplifting the voices of those fighting for healthcare reform around the country. I'm Brenda Gazar.